Hey y'all, it's Dr. Hall again, and I get asked this question a lot. I'm a nephrologist, by the way. I've been practicing for about 20 years. I know I don't look but about 35, but we're gonna talk about collaborative care and referrals. I get asked a lot of questions when patients get close to dialysis. How can the primary providers collaborate with the nephrology team to make the transition easy? Now that's a great question because we want our patients to actually retain their primary care provider once they get on dialysis. They still gonna have pneumonia, they're still gonna have bronchitis, pharyngitis, sore throat, toothache, ingrown toenail, arthritis, neuropathy, you name it. So we want to make sure that that transition is effective, but also that the patient is not dumped on a nephrologist and the primary care providers know that you're still their primary provider. So, first question, how can I effectively collaborate with a multidisciplinary team such as nephrologists, dietitians, social workers, dialysis nurses? I think the biggest thing that you can do as a primary provider is communicate with the nephrologist about the timing of when the patient is going to be on dialysis. Because once that kidney function gets below 20%, that's when we're all on high alert. We're looking like, okay, they're going to be anemic, they're going to be hyperkalemic, they're going to start having swelling, they're going to start having a lot more acidosis, and we're going to have to make some changes. When they get to around 16 milliliters per minute, the GFR, we really want to try to get a peritoneal dialysis catheter or an AV fistula in place. So that's kind of our approach when they get to this level. And when they get below 15, we look at starting dialysis. I had to start a lady today on dialysis because her GFR was around 10. Now, she was asymptomatic, she said, but patients know that dialysis is coming. So a lot of them will tell you, I feel fine, I don't have any symptoms. But I never really buy that when your GFR is 10. You got to feel something. However, if your GFR goes from 100 to 50 overnight, you'll probably feel it. If it goes from 100 to 99, you're not going to feel that. So these patients there's a subtle decline in the GFR, and they don't necessarily feel it, like from 20 to 19 or 19 to 18. It's not really appreciated much in the way that they feel by some patients. Some patients, they feel bad all the time, no matter what their GFR is. So ultimately, though, we want to be able to communicate, collaborate with the primary care providers so the transition will be easier. I think just you guys as primary providers can support your patients. Let them know that they can call with primary issues. One thing I want to throw out there for you guys that I've noticed, some primary providers will comment on dialysis, such as peritoneal dialysis is not a good dialysis regimen because of the infection risk, the peritonitis risk, or peritoneal dialysis, you don't need to do that because you're too old, or other issues or comments. Honestly, peritoneal dialysis is the best type of dialysis, and I'm going to do a video on that. It is the best type of dialysis. Patients' residual renal function lasts longer. That means their kidneys will stay at 10%. If they start on dialysis at 10, they will stay at 10 longer. There's a lower hospitalization rate with peritoneal dialysis patients. And here's the kicker. They have a higher transplantation rate if they're on home dialysis because they're healthier. And that's what we want. We want our patients to be healthy. The peritoneal dialysis modality is the best way to go outside of getting a kidney transplant. So if you want to help your patients, talk to them about home dialysis. That is the best way to go. Going in center, dialyzing 3 days a week is not the best form of dialysis available in 2025. So you guys can just educate yourselves, get on board, so that your patients will stay educated when they ask you questions, and you can be, in agreement with us nephrologists on what the patient needs. The next question: what are the indications for discussing renal replacement therapy options, such as dialysis or transplantation, and how can I facilitate the transition? When patients get below 18, we really jump on the educational CKD education department. Most dialysis units have a CKD educator that kind of floats around. She'll meet them at our clinic, she'll meet them at the dialysis facility, she'll meet them at their house, she'll meet them by Zoom, and this helps facilitate that transition. Because when they get to 18, we got to really start talking about what's next. What modality you want to do. In-center hemodialysis, home hemodialysis, or peritoneal dialysis. All patients should be referred for a kidney transplant when they get to 20, GFR 20. So we try to do that in our patient population. We try to refer all our patients to a transplant center or two transplant centers so that they can actually start the process before they ever get on dialysis. So yes, patients can get a kidney transplant before getting on dialysis. I just kind of felt that question coming through the wire. I get asked that question a lot. Matter of fact, we would love for patients to get a kidney transplant right at that point when they're 15, 16% or 14%, and they may not have to go on dialysis. That's the most ideal situation. But in America, there are probably 500,000 end-stage kidney disease patients on dialysis, and there's just not enough kidneys available. So some patients are going to have to dialyze. Next question: how can I improve care coordination for patients transitioning between different care settings, inpatient to outpatient, primary care to nephrology? Well, primary care to nephrology, we want to retain that relationship. We want patients to continue to see you every 3 to 6 months as their primary doctor. Their diabetes and their hemoglobin A1C needs to be looked at. Their blood pressure needs to be managed. Their health screening, such as pap smear, mammogram, colonoscopies, digital rectal exams, and prostate exams, all these things have to be done on dialysis patients, just like non-dialysis patients. And the primary care providers are the gatekeepers for all that. So we encourage you to continue to see your patients, continue to make an appointment on your books with them so that they will not miss anything. And more importantly, if all that's up to date, when we refer the patient for a kidney transplant, everything can just be forwarded to the transplant center, and the patient will already have had a transplant workup, which includes all of that we just talked about: pap smear, rectals, mammograms, EKGs, etc. So that's one thing from primary care to nephrology transition that we recommend. Inpatient to outpatient, we try our best to start patients out outpatient when they start dialysis. It's really hard because of just the dynamics of patient care and the dynamics of trying to consult the surgeon and get the catheter in and coordinate with the dialysis center, but it's possible. I'll give you an example. Today I admitted a 54-year-old black lady to the hospital because her kidney function had dropped fairly quickly over the last several months. It was hovering around 15 to 16 milliliters per minute, and we checked it recently and it was 10. So I could try to get her a PD catheter and rush, try to start urgent PD, but it would be really hard to do that as an outpatient. So I just pulled the plug, admitted her to the hospital on yesterday evening, consulted the surgeon. Today she's getting a peritoneal dialysis catheter, and she'll actually be starting peritoneal dialysis tonight or in the morning. That's usually the typical situation. She will continue to see her outpatient doctor for her regular appointments, but she will see us once a month for her dialysis appointments. We would train her how to do the home dialysis, and I really expect this young lady to do well. She works at a school. She has good insurance. She's active. She's young. I think she'll probably get a kidney transplant. The average wait time is 3 to 5 years, but she'll probably get one sooner than that if she takes care of herself and does well. So this was a YouTube video that talked about collaborative care and referrals and how we nephrologists collaborate with you primary care providers. Hope it was helpful. Stay tuned for the next video. We're going to keep them coming because I want to bridge that gap from medical knowledge to clinical practice. We want to teach you to do what we do as nephrologists and show you how to be excellent clinicians. That only comes from reading and seeing patients. If you're only reading, you're going to have all the book knowledge, but you're not going to know how to use it. If you're only seeing patients, you're going to know how to do some stuff, but you won't really know why, and you won't be able to manage a lot of side effects. So, both are necessary to become an excellent clinician and physician or a healthcare provider. So I encourage you, study hard, read a lot, check out videos like mine, check out the webinar below like mine, and hopefully we can help you guys bridge that gap. Thank you. Please ask me more questions so I can fill some of your questions, and subscribe to our community where we have an ongoing discussion about nephrology related issues. Thank you for tuning in. Goodbye.